whatnot, got a lot of back and forth with it. And so after a lot of conversations with all the people around the program and stuff, the decision has kind of been made that it is okay. These patients can be in NICU. You know, some of these patients, for the stuff that is run on them is stuff we run in other situations sometimes and everything. So just wanted to get you guys the training and education so that you're familiar with some of the medications and some of the disease process with it when you're using them for patients with pulmonary hypertension. Respiratory therapy is also getting a lot of education around this. They will be the ones that are kind of going to be responsible for some of the medication administration because a lot of it is inhalation stuff. Some of it's stuff that patients do independently when they're able to. So RT will kind of take that ownership as far as the medication piece goes, but obviously clearly work in conjunction with them, talk to them if you see some things maybe not being marked as done on the EMR or you're not sure about a medication of who's responsible for making sure that it's administered. Talk to your RT about it so that we don't miss giving medications to patients by any means, but it will definitely be a conjunction, multidisciplinary process in caring for these patients, making sure they're getting the meds and everything. So I'm going to turn it over. This is Steven. Hello. He is one of the educators with the cardiac service staff, specifically with the pulmonary hypertension.
All right. Hello, everybody. I know you're excited to be here. Again, my name is Steven. I'm going to try to do this within 20 minutes. It's going to be difficult because it's a very complex disease, and I'm going to try to break it down for you a little bit. But real quick, we're going to talk about our team. The director is Dr. Ashwin Ramachandran. There's myself and Christy that are coordinators. I even threw on my cell phone number, not my personal, but my work cell phone number. Feel free to text me or call me. I'm very available. Main cardiologists are Ramachandran, Sudharshan, and Morris. And then the people you're discussing for inpatient care is advanced heart failure cardiologist or team T. So anyone that you have that has heart failure, they're the same ones that are rounding on these patients. All right, so what is pH? So pulmonary hypertension is elevated blood pressure in the pulmonary artery. That doesn't mean a whole lot. You can have a dilated PA for a lot of different reasons. So there's a lot of pH, very little PAH. The difference is pulmonary arterial hypertension is defined as elevated cardiopulmonary pressures due to either the narrowing and stiffening of the arteries or arterioles in the lungs, fibrosis, inflammatory processes, and a blockage by embolism. That said, because there's a lot of different reasons why someone may have PAH, and we'll discuss that shortly. But to be PAH has to be determined by a right heart cath and demonstrated by a mean pulmonary arterial pressure of 20 or greater, a wedge less than 15, and a PVR greater than 2. For everything that is considered PAH is going to get PAH modalities. So disclaimer there, we'll talk about in a second. So you've had a right heart cath, you've been told that you have PAH. What does that mean? So as you look at this sheet, there's 5 different WHO group categories of PAH. Predominantly, we're going to talk about 3 of them today, mostly WHO group 1. WHO group 1 is kind of idiopathic. You've got a genetic predisposition, drug toxin, either you really love meth or you're a little old lady whose doctor prescribed you amphetamines when you were younger for weight loss and now he's giving you PH. Could be a whole slew of connective tissue disease, scleroderma, or lupus can cause it. 1 out of every 200 people with HIV, hey, you get that too. So you kind of see all these different things. The WHO groups, interestingly enough, are not necessarily defined specifically as to what caused the PH, but what the treatment modalities will be. So WHO group 1 gets the most treatment. We'll skip real quick to WHO group 2. That's left heart disease. All we're going to talk about WHO group 2 is right now. That means someone wasn't treated well on their left heart disease and has gotten so bad it started to affect the cardiopulmonary pressures in the pulmonary circuit and in the lungs and affecting the right side of the heart. What do? You treat them for left heart disease. Nothing's changed with that patient. So that's that. Then we go to group 3, and that's PAH due to lung diseases. We'll talk a little further about that. It's usually fibrosis, but there's about 200 different qualifying interstitial lung diseases that can cause PAH. Group 4 is CTEPH. Basically, you've got a pulmonary emboli in your lungs. That's caused the blockages in your lungs. And then group 5 is multifactorial, usually cancer or oncology. We're not going to discuss that much because we have that triage through work 1. When the referrals come in, those people will land on, obviously, hematology cancer floors, right? So you won't see those people. Moving forward. So pH, WHO group 1. Remember, this is that idiopathic or drug-induced or the kind of the big brouhaha of who's going to get the most medications. Again, it's characterized by the hardening and thickening of the endothelial lining. What is that? Here's an arterial. You see you got a normal vasculature there. Here you can see that inner lining starting to thicken and close, and in a sense causing stenosis back up in those arterioles. You got thousands of them there in the lungs, and eventually builds up that pressure. It is the most rare group of PAH. It has the most medications available, and also, oddly enough, it's the one that had the quickest response to the medications. These are the easiest to treat. So another way of looking at it, you'll see on the left, you got the clear flow of blood, and that's kind of your normal vasculature. Then you've got a little bit of buildup along the side. You kind of see how that would start to break and build up some pressure. And then the advanced stage, which is probably what you're going to be seeing, is going to be closer to this, where you have near closing of the artery. So there's almost very little room for the blood to flow. You've got advanced lesions that are then breaking out into part of the lung and the airspace. So it's basically aggressed to a point where these are the ones you're going to be seeing. And what it's going to look like when you think about it is you got your normal heart and lungs, and then you got your heart and lungs on drugs. Sorry, you got your heart and lungs on PAH. So blood vessels, again, arterioles thicken. You're going to eventually, when that pressure builds up in those arterioles, it's going to hit one of two places initially, right? It's going to hit the left atrium. It's going to hit the right ventricle, because those are on both ends of the pulmonary circuit, right? So what we're going to have when you see your patients with PAH, this is what they're going to look like. They're going to have a dilated left atrium. They're going to have a dilated right atrium and a dilated right ventricle. What does that mean? Well, I'll tell you what that means. That means right here, we've got diastolic dysfunction of some kind, right? Usually at least stage 2 or stage 3. That's why they're hypervolemic, right? Because that's going to create a big backflow into that circuit and through osmosis and all that good stuff. Then we have edema. It's also going to prevent blood flow from coming in so that it can get to the right ventricle properly, right? Then not only is the RV dilated and pushing that septum over to the LV, but the RVEF is reduced. So that function. So now its function is reduced. It's trying to push against pressures in the lungs. And then you got a left atrium that can't even receive the blood if it does get there. Then you got the left ventricle. Well, of course, obviously we have hypertrophy that's going on there, potentially a reduced LVEF. So they're going to look like patients that look like they're on acute or chronic exasperated heart failure, right? Because in a sense, that's exactly what they have. And if they are WHO group 1, the underlying cause is PAH, but it has gotten to a point where it's actually caused heart failure on both right and left side. So, sounds fun, right? Who wants one? So acute interventions, what does that mean? So like in our acute places like the MICU or CBTU, a lot of stuff isn't going to change initially because we're not just going to throw oral medications at this patient. It's not going to work. So obviously we're going to be focusing on acute heart failure and PH. You're going to be looking at kind of a lot of the standard stuff. IV nitro, that's going to be a powerful vasodilator, right? We're going to try to open up those vessels that we saw that got closed and get that blood flowing. A lot of them are going to be vent or some kind of advanced airway, tons of oxygenation. We're going to have possible high flow devices like Airvo if they're lucky. So oxygenation, we'll talk about that real quick in advanced airways. One of the reasons why that happens is because where those arterioles are, and you've got that blood flow being blocked, what happens in the arterioles? Anybody? All right. Diffusion. So process of oxygen coming in and attaching to the heme group in the blood, right? And CO2 coming out. So all that pressure is limiting their ability to diffuse even the poor amount of blood that's going through the lungs. So that's why a lot of these patients, they'll get them and they'll be trying to bring them in on an ambulance or whatever. And they're like, we kept putting in oxygen. It didn't change anything. No, because that pressure is such that the diffusion is so bad, it doesn't matter how much. So that's why they usually end up on an advanced airway, because we're going to have to help them out for a while. Again, nothing new to you guys because you'll do that all the time. Inotropes, right? Butamine, melanoidone, possibly vasopressors, depending on what that's going on. Because yes, you can have elevated pressures in your heart and lungs, yet also low peripheral, right? Because all those vasodilators are going to cause lower blood pressure. And in severe cases, then you might see some ECMO because we're going to need some circulatory support as we get them calmed down. So a lot of these patients are going to look like just a normal acute heart failure patient that some of you guys have probably dealt with before. With that being said, once we've got them stabilized on those, then we can look at what's considered the traditional pH medications. So there's three main types. The white and the black are ebony and ivory. We've got PDE5s and ERAs. And I'm not going to go through all of this. What I'm going to notice is there's a tadalafil that's bold and opsumit that's bolded. Those are the two you're going to see us give these patients in hospital. Outpatient, there may be a lot of others, but those are the two primaries that we're going to do. Now, why do we do that? It's like a 1-2 punch. Remember we talked about what's going on in those arterioles? There's a little bit of closing and stenosis of the interior lining of the arteries. So the ERA is going to stop that from thickening from happening. And then the PDE5 is going to vasodilate. So that way we can open up the vessels, prevent further damage, and hopefully at that point be able to allow blood to flow. Now, in most cases, they're going to need a third medication, which is where prostacyclin comes in. So if you think about PDE5s and ERAs, we talked about stopping it from thickening, opening up the vessels, doesn't fix anything, right? I mean, it's really not a fix, it's not correcting anything. Prostacyclin can remodel the vasculature and start to thin that thickening out. Now, with that being said, the two most you'll see would be Orenitram or Remodulin that are oral and IV sub-Q. We do not do a lot, especially coming right off of like an ICU type setting of the oral Orenitram. We may do a couple of Remodulin. The biggest thing we like to do is inhaled prostacyclin. And we'll talk about that a little bit later as to why, but it's a lot easier. And that's also the one that RT is going to be delivering. Quick thing about Remodulin, just so everybody knows, if you see it, which again, we do it rarely now, it is IV or sub-Q. You do not want to flush the line. It is a very potent medication down in nanograms. So if you flush it, that 1.2 that's in that lumen is enough to potentially cause a sentinel event. So we never flush it, never use it for anything else. There's like pharmacy will help you through with the cartridges. There's a sheet that we're making, right, that will help with the guideline on that. There's a 2 nurse check to make sure cartridges are changed. And then the only thing I'm going to say about PO, if you see someone with the Orenitram, they have to have food with it. So they can't be NPO, which is why, again, you won't see a lot of those patients in your setting in the acute situation because most of them aren't eating. You know, and when they finally do, they're not eating enough for us to be able to do that kind of medication. We're lucky sometimes to get them eat once a day, right? Let alone 3 times with the medication. So generally, you will not see that. Other floors will. Adverse effects of prostacyclin. So if they're on Remodulin or that oral PO, this is what they can expect. They will have headache, jaw pain, nausea, vomiting, diarrhea, extremity pain, flushing, and thrombocytopenia all at the same time. The infusion of Remodulin is very tough, and we pre-treat with H2 blockers, antiemetics, pain medication, steroids. You can read the rest. Wait, like 30 minutes before we even start, 30 minutes before each titration of the med, because they will have all of this. It's almost like getting, I don't want to minimize cancer, but it's almost like if you think of cancer therapy, how it wears people down, it will wear them down. It'll save their life, but it's a tough few days when they start that. All right, the last thing, if they come in, you see somebody who is on a pump with Remodulin, and there's another one called Velitri, but we have one patient on Velitri. Velitri has a half-life or flow-land of 6 minutes. So if they've got a cracked catheter or roll over and disconnect it, we have to be quite aware of that, which is why we don't like using it outpatient, because obviously at 6 minutes half-life and 30 minutes that med's gone enough that it doesn't matter. So they will go into what's called rebound PAH. So what happens is if they're on IV sub-Q and they lose it, Remodulin's 4 hours, so we usually have enough time to catch that. But they'll go into acute respiratory decompensation, tachycardia, hypoxemia. Basically, we'll end up probably venting them again. It's pretty rough. But key thing is just to know that the half-life is pretty quick, and we want to make sure that if we do have someone like that, which your chances of seeing them is pretty minimal, keep an eye on those those lines and the pumps. Remodulin comes in both a little sub-Q pump and then the IV. Most patients, though, if we start them, we're going to start them in IV, and they'll have like a Hickman or a PIC.
How long does the Remodulin infuse for? Is it continuous?
Continuous, yeah, it's a continuous infusion, and they'll have it lifetime unless we get them off the Remodulin onto either PO or the inhaled. So particularly, you may see that temporarily while they say vented, because we may have a hard time starting inhaled, although we have had people where we've taken them temporarily off the vent, do the inhaled, and back and forth. So, good question. So talk about this for like 3 seconds. There's a 4th medication. Some of these PH people have 4 medications. It's called sotatercept or Winrevair. It's an injection that they do sub-Q every 3 weeks. So if you think about it, first you have to have a patient. Then they have to have the timing of it. We're not going to have it on formulary. The patient, if they're here at the time they need it, will just do non-formulary. They know how to self-inject, or and we'll write it that way so that they take care of it. But you can also just partner with us and be like, dude, what's this? But it is something that could potentially be seen, but it's not something we'll have in formulary. All right. So then we're going to talk a little bit about WHO group 3, and then at the same time, these inhaled prostacyclins, which seem to be the most confusing for some people. WHO group 3, remember, is the interstitial lung disease. So again, over 250 qualifying types. It's usually fibrosis. IPF is a very aggressive disease. These patients are probably have the worst outcomes because they have multiple comorbidities that are of the pulmonary. And they may have like bronchiectasis as well as COPD or emphysema. Then they have fibrosis, and it's called PH. So there is really only one option for these people, and that's going to be the inhaled prostacyclins. You can see here key pathological mechanisms is inflammation, proliferation, and fibrosis. So just these high amounts of inflammation and fibrotic processes in the lungs that are basically squeezing on those arterioles and closing them off. So again, what's going to happen is this is our usual effect for that 3rd therapy, right? We've got the 1-2 with the opsumit and tadalafil that's going to open up the vessels and stop the thickening from happening any further. Then we've got the prostacyclins. So there's a nebulizer, which is like this little mechanical device. We carry that in formulary. We have a couple units usually on stock in our pharmacy. What will happen when this gets ordered is RT is able to administer this immediately once we put the orders in. Myself or the other coordinator will come and do education with the patient when we, at some point after the start. They'll monitor the patient directly afterwards, and then we'll talk a little bit about some of the potential side effects you may see, throughout the course of the day as we start this medication. Obviously, as you can see, this is a little bit more of a complex process for the patient. Since it's a nebulizer, we've got distilled water that goes in there, little ampule, a medicine cup, and all these parts and pieces that go together to make this nebulizer. They've got to clean it at night. They got to set it up in the day. Pharmacy will, RT will be starting it, but at some point in the course of their hospital stay, one of the goals is for them to self-administer, because if they can't do that, they're not going to do it at home. What does that mean for nursing, or if you've got an MA? Then obviously, if they're bed-bound or chair-bound, which most of the intensive care units they are, we do need to help them at the end of the night, give them like a little bucket or something so they can wash their parts and pieces. We'll be training them on what to do for that. RT will be helping with that as well, but at night, that's the one thing they'll definitely need some help with, because they can't just go get it on their own. Medication symptom management revolves around number 1, throat protection to inhalation. The prostacyclin is an irritant, and so if they breathe it in and it gets on their back of their throat in the bronchioles, it'll start causing constriction, irritation, and cough. So there's a lot of things we've gone over with RT about proper ways of administrating this. But number 1, if they continue to hydrate their throat and they continue to take a little water before and after, that will help a lot with the cough.
A quick question.
Sure.
Abby, so RT is gonna be doing, I had a patient once on that, it was very complicated because we were doing it, RT was not, but it's gonna be RT.
Yeah, RT has been like you said, there's been lots of meetings around that and conversations, and yes. RT has been trained on the Tyvaso to kind of take the lead on doing it with the patients, and then like Steven said, like teaching and training the patients so that if your patient's X3 and they're doing patients eventually start doing it themselves. And that's why I would say working with RT, because if it's the point where the patient's doing it, it may be that nursing, like you just need to give the patient the stuff to do it. But then if the patient ever has a decline, if they can't do it themselves or they can't do it with RT and stuff, that's where we as nursing need to make sure we're letting the pulmonary hypertension physicians know that. So that they know if there are doses that are not being administered or having to be skipped because the patient's condition doesn't allow it to be administered and stuff. One of the slides made mention in there of like starts out with like 3 to 4 puffs, but works its way up to like 21. And the system, our EHR is set up to have those increasing doses built in there. So if we have held doses and not administer them because the patient condition doesn't allow it, and then all of a sudden 24 hours later, they can start doing it again, we have skipped multiple increasing doses, and now we're going to give this patient potentially a significantly bigger dose than what they can probably safely handle and could have significant side effects. So we just got to make sure if the patient's not able to get it, that we're communicating it to those doctors to let them know that it's being held.
Yes.
Thank you.
So yeah, I've sat with RT, I've given the heads of RT, their team leads information on this so they can disseminate it to their RTs on what to do. The problem is this isn't something that you see a lot of, which has caused a little bit of problems. But the other problem is almost everything that has to do with inhaled medications, RT's been doing for quite a while now too. So we're just kind of getting it in to be compatible with the way everyone's used to everything working, which makes the most sense. So that is the nebulizer. Then we have what's called a dry powder inhaler. It's a little simpler of a process. It's kind of the newest line of these inhaled prostacyclins. A lot of our outpatient people have already been transitioned to either what's called Tyvaso DPI or Yutrepia, which are the 2 different types of inhaled. And there's several advantages, like there's a lot less side effects with them. We titrate faster. There's no setup or cleanup. It doesn't have an electronic device or a battery that you have to charge. Instead of doing up to 21 breaths, you may take 2 cartridges or 2 capsules and you breathe that in and you're done. So you go from an administration time of 5 minutes or longer to a minute, of a dry powder where you just, and it's done. And it is also more efficient and accurate. So the other problem with that inhaled nebulizer is even the manufacturers say, well, depending on how well they do with positioning and breathing, it can be anywhere from 3 to 6 nanograms. So we're talking about 100% difference. So being able to dose and understand how much of a dose they're getting is kind of difficult. So this will give us that ability. So the Tyvaso, I'm just showing you real quick so you know what it looks like, because just like everything else, right? You've got like you won't have dual nebs in your nurse server. Usually you'll have like an Oro or something, right? Let's go in your nurse server. That's what these will generally be kept. So little bitty devices that fit in your palm of your hand. They open up and the little cartridges go in and they close. The interesting thing is the Tyvaso DPI, as I've explained with RT, is really position dependent. They have to really focus on what they're doing. Whereas the Yutrepia, the newest device, which does look a little different, it's blue too and white. I don't know why they're both blue and white, but it uses these little capsules. It's not position dependent, so they can do whatever they want with it. It's a low resistance, so it doesn't take as much of an inhalation. And this we're working on having as formulary in the next 2 months. And what will be nice about this is this will simplify that whole process significantly. So I know you've seen the nebulizer part of it. The worst thing I do is every 7 days, throw that away, and get a new one and put a capsule in. But it'll also allow us to make sure that we can get it done quickly and titrate fast. So that's nice. So inhaled prostacyclin, there starts titration starting at 23. We do titrate very rapidly. So this is the key things for you guys to know as far as nurses. There are certain side effects they may be able to get that RT is not going to really deal with. They're not going to go run and grab Tylenol if they have a headache or Zofran if they're not nauseous. So when we put the orders in for inhaled prostacyclin, there should already be a set of PRNs that flow down there. So my suggestion or ask would be that if you see that order, double check to make sure you've got your PRNs. If you don't, contact Team T, contact me, I'll put them in. Not everybody needs them, but when they need them, you need to be able to have access to it because it's going to make your job a lot easier if you can just grab some sublingual Zofran versus waiting around for someone to put an order in. So I suggest, not again, especially when they first start on a lower dose, they may not have anything. It is possible for them to get a little bit of a headache, which can be relieved by Tylenol. It's not a big one. Potentially nausea, again, Zofran. For our group 3 patients, I've talked to RT. They're going to preemptively give the patient albuterol 5 to 10 minutes before the treatment for the inhaled prostacyclin. That's going to help open up those bronchioles. Remember, I told you it's kind of an irritant. It helps to close. Well, a lot of these guys, again, have multiple pulmonary issues. And if we can even help just a little bit support that airway, the main airway, we'll get that medication to the deep parts of the lung where it needs to go and minimize irritation, which will help the patient and you guys out at the same time. It is also right, if this person's on these, they're probably on other medications with a powerful vasodilator. So we can have some rebound hypotension with that. We understand, especially within the first hour, is when you're going to see the most of that. Now, most of your patients will probably be fall risk anyway, but we always say make sure they're fall risk when we first start this. And know that if you see that drop within the first hour, then that's typical. The other thing I would say is, and you're not the ones doing it, but if they complain about a cough and they're doing like an inhaled prostacyclin, we want to make sure we use the minimum amount of cartridges possible. Again, it's an irritant, and I had a call because I had a pharmacist, and this is an example of what really happened. Patient was on 64 micrograms, and the pharmacist wanted to use up the old 16s. We had him breathing in 4 cartridges, and the patient was coughing like crazy because it was just irritation after irritation after. Each time you do another cartridge, it's just worse. So we want to do the least amount of cartridges, which again is one of the reasons why we like the Yutrepia, because you have a higher dose of cartridges, or they have capsules, but it'll minimize that significantly. So when we do these inhaled prostacyclins, generally what will happen is, like she said, if it's an inhaled nebulizer, it'll be like 3 breaths, 4 breaths that we start, and each dose it will be increased. So if we start in the very morning and it's 4 doses, they'll be at somewhere around 12 to 16 breaths, and by the morning they'll be at max dose. So because of that, that's why we want to have those PRNs, because they have the most chance of having any of those side effects. I would also suggest that if you have a patient where maybe they're having some of these side effects, again, not just the Tylenol, it's fine to give them the Zofran before they get the treatment if you know when that's going to come up. I know it's sometimes hard to pair with respiratory. I get it. I've been on the floor and you're like, dude, why is this red? Can I get my Duonebs? I get it. But, that's what you can have. My suggestion is the best that you can. That'll help the patient. That'll help you guys out with call lights, things like that. Lastly, group 4, and you guys should not see these, but we're just going to talk about this because these should all go to CVTU. This is very simple. They have chronic blood clots or MLI in the lungs. Those clots have started to calcify. It's not just that they have a clot, but this calcification starts to form over the clots, and then it forms a bridge between the clots and basically knocks out like little chicken fingers throughout the arterioles. And it'll block out a whole half a lobe or even 2/3 of a lobe, depending on which side you're on. And then we will then do a couple different things. If it's a surgical cure, it's Peter Waltz through the CV surgery chain. If not, we do a couple meds, Dempus and Opsummit, to be able to treat them. Real quick, just so you can kind of see what I'm saying. Obviously, this isn't all clot. You can see the dark red of the clot, and then these calcifications that just kind of fingerling. And that's actually a mild case. Most of them are a little worse, much worse than that. And it just takes out, like I said, a whole lobe. We'll start a Dempus prior to the procedure, and then we maintain usually afterwards for a little while. We found that that helps aid in the success. Again, we talked about we're going to review with cardiology, CV surgery, IR, pulm. We all kind of collaborate. We're only one of two hospitals that do the procedure. We used to be the only one, but now there's two of us. And then they'll need lifeline anticoagulation, obviously, because they've got chronic blood clots. But this should go to CVTU because they'll go in there, get ready, and then be discharged by CVTU at the same time. We usually don't even send them to the floor. All right, basic recap. Not all pH is PAH. You know, there's a difference between pH and pulmonary arterial hypertension. The arterioles begin to thicken and close. Pressure increases, reducing perfusion and diffusion. Symptoms usually mimic heart failure because they're in acute heart failure. SOB, chest pain or pressure. The one thing I will say is that's one thing, especially in our EDs, that confuse patients or confuse hospital workers, is they may say chest pain. Most of them will say chest pressure. It's centralized. It's not here. It doesn't grow through the arm. It's usually centralized, and it feels like somebody's pulling it right through the back of their chest. And the reason why it's not a myocardial infarction, right? We have a pulmonary infarction where we have that ischemia in that area, and that's why it kind of sits through here and then pulls back. So it may seem like they need nitrac, but they don't because we already have them on powerful vasodilators. So we definitely don't want to give them any kind of nitric because then we cause a lot of problems. Fatigue, cough, edema, dizziness, palpitations, and then you may see a late stage blue lips and fingers because the peripheral is getting. All right, and then any questions? Sorry, I know I did that fast.
Questions you guys have for pulmonary hypertension, the patients you might see, the treatment, anything? Yes, yeah, Nicole shared them with me and stuff, so I will send them out to you guys so so you guys can have the access to these as resources. So.
But also you have a PAH one-page guide, a key assessment guide that has most everything he set up there on there. So it has a lot except for the new groups. The medications on the back, the nursing considerations for each of the medications, a table's on the back for you guys as well. So another resource that you guys can use.
You know, the other thing I didn't say yet that I usually say is don't hesitate to call because like I work with these patients in the outpatient setting, so I'm their lifeline. Christy is there too. So the same for the patients she works with. So a lot of times, especially if there's hyper anxiety involved, we can come to the room and just knowing that our presence is around will help calm them down, allow you to do your job the way you need to. So we can be that calming presence if you need to, help them out. So definitely don't hesitate to call. We usually will round on the patients anyway, but if there's any kind of situation where maybe they're getting a little antsy and you're struggling to get things done, that can really make your job easier because we can come in and like, oh, good. Okay, someone's following. Because you know how it is. They will see a rounder, but they may be half asleep and they don't know who's actually being taken care of them. And knowing that someone that knows them and knows their condition will make a big difference.
Who would be the, or go ahead.
Will someone be available on night shift if we were to have something like that?
Not right now, unfortunately. So
Who would be the person if Night has questions, needs support, needs assistance with something, like who is the
we
person?
talked about
for them to get a
including
hold of?
we talked about including the cardiac research, but I don't think that's been done yet. Team T has the Team T rounder has a nighttime call.
Night call person.
Yeah.
So that would be the night person resource. Would be whoever is covering for Team T at night would be the resource for night shift to reach out to. Like if you guys have questions about any of it, have problems, have issues with anything related to pulmonary hypertension, meds, the patient, anything like that, I would say that would be the person to reach out to at night. Would be who? The team, whoever's covering for Team T.
And then are they actually in the building?
It's gonna be cars.
Is the team
It's cars. They've got
Yeah, it's the Team T cars, the cardiologist. So like Ramchandran or Chaudhry or Patel or whoever is going to be in that call group. But that's good. We are working on that as far as trying to figure out who that could be available.
Any other questions you guys have for? No. Thank you. Thank you.
Thank you.
So you